So one more example of problems at the capillary level. This is in the kidney capillaries, in the glomeruli. So as you might know, the endothelium in the kidney glomeruli capillaries is specialized, obviously, to filter lots of fluid. So they have these fenestrae. So on the left is a schematic on the anatomy of the glomerular capillary endothelium. So on top is the lumen with the high albumin content. And then the endothelium has these big gaps called fenestrae, which are wide openings of 40 to 100 nanometers big, which is much bigger than the size of albumin, which is only about 6 nanometers in diameter. So you would expect a lot of the albumin to flush out of the kidney capillaries through these big fenestrae, but it doesn't happen under normal physiological conditions. And then you have your basement membrane, and on the urine side, on the Bowman's capsule, you have these podocyte food processes that line the lumen of the Bowman capsule. So if you look with the EM on glycocalyx, where glycocalyx is in these capillaries, again, on the top is the lumen where the blood flows. On the lower left is the urinary compartment with the podocytes, the basement membrane. So here's the endothelium. You might see these black spots in the endothelium, which is a lot of glycocalyx staining inside these fenestrae. So these openings are not really openings. They're filled with glycocalyx. And that's the reason why albumin doesn't leak out of the bloodstream into the urinary compartment in healthy kidney capillaries. Then if you take away glycocalyx in the middle panel, now you see with an enzyme called hyaluronidase, and now you see these transparent openings. So now you have taken away glycocalyx from these fenestrae. Now they are really open, and you can start leaking albumin. And then on the right-hand side, when you zoom in on the podocytes, after you disrupt glycocalyx from the fenestrae in the endothelium, now you see these little black dots, which are individual albumin molecules that were stained. So now albumin can leak out of the blood compartment, hits the podocytes, now starts sticking to the surface of the podocytes, and the podocytes get sick. They internalize all the albumin that they usually don't see. They start retracting and detaching from the outside of the capillaries. And there's a little animation that illustrates that, if you don't mind me showing. It is in Dutch, but no, I think it's
We'll see how
explaining.
we do with that.
We have a lot of Dutch-speaking people there in the audience.
No.
Probably not, but I'll explain a little bit. So it's easy to follow. So this tells you a little bit about the development of kidney damage in diabetics, and it shows how blood flows into the kidney. So we have arterial flow into the kidney, venous flow out of the kidney, and then if you zoom in on the glomerular units, this is a unit, glomerular units with a capillary flowing into the unit. And this is the outside of that capillary with the podocytes. You see a lot of podocytes really enclose the outside of the capillaries with these podocyte fingers. And only very small molecules can leak out of the vasculature through the endothelium and through the podocytes into the urinary space. Now, if you look on the inside of the capillary, you see there's a glycocalyx, and that the bigger molecules like albumin bump off glycocalyx, don't leak through glycocalyx, don't see the fenestrae. Only the very small molecules can. So in diabetes, when you damage your glycocalyx, all these fenestrae now become exposed, big holes that are open now, and albumin is able to leak through the fenestrae. And now see the outside, and the albumin hits the podocytes. Now the podocytes' fingers get sick, they retract and detach from the capillary. So now the capillary becomes completely exposed on the outside. There's a lot of leakage. And then as an attempt to start repairing that damaged capillary, there will be fibrosis on the outside, covering up the capillaries again as a scar tissue formation to try to rescue the capillaries. But if that continues, all the fibrosis will just kill those capillaries in the glomeruli, and whole glomerular units will die, and you will start losing filtration capacity. The more units of filtration you start losing by that process. So I hope that was a little bit clear, even though it was a Dutch animation. Let's move on. Yeah.
You guys have questions so far?
I have one. Is there any positive feedback situation where there'd be a regulation, the down regulation, the volume of glycocalyx to, I don't know, as an immune response or something like that?
Hans, did you hear the question?
No, can you repeat? It was a little bit soft on my end.
Is there any like positive feedback situation where the volume of glycocalyx would be down regulated to, I don't know, increase volume of red blood cells in a situation? Is all
Yeah,
loss of volume bad?
yeah. So if you lose a lot of volume, you have your even similar like other ways of losing volume, like in hemorrhage, or when the vasculature becomes hyperpermeable, like inflammatory situations. So yeah, the first thing you will notice that your blood pressure will drop, the heart rate will go up, and your body tries to make new glycocalyx all the time. So it depends on the magnitude and the duration of the stimulus. And if it's chronic, then and if the permeability keeps being high and elevated, you will lose a lot of volume, but at the same time, you will shut down a lot of your microvasculature at the same time. So that at some point that will limit the amount of leakage and the volume loss, but at the same time you lose a lot of functionality and exchange capacity. So you might be able to prevent the volume loss, but then you lose exchange capacity and organs will starve and will suffer damage at the microvascular level initially, and that will add up at some point and lead to organ failure if it isn't taken care of. So yeah, there's instead of you try like in acute settings like in the ICU, what they try to do, they resuscitate and they add a lot of additional volume. What you have to do to keep blood pressure up to a minimal level to keep your organs perfused, but also you have to be very careful how much volume you give, because all the volume that you lose is stored in your interstitial space in your organs and your tissues. But as soon as you are able to take away the stimuli that break down glycocalyx and glycocalyx start recovering, there's this the osmotic gradient is over glycocalyx that usually prevents the leakage of all those fluids. Now, if all those fluids are outside your vessels in your tissues, you start repairing your glycocalyx and you rebuild that osmotic gradient over your glycocalyx, and which will pull fluids back into your vascular space. Well, at some point, if you have excessive fluids administered, and I've seen cases when I'm still teaching in the clinic, that people would give like 5, 6, up to 10 liters of additional fluid to try to resuscitate patients' blood pressure. Or if those 5 or 10 liters try to flow back into the vascular space when glycocalyx is recovering, you switch from severe hypotension into a hypertensive crisis, and that's very difficult to mitigate. And then people die from almost exploding blood vessels when blood pressure gets way too high when all those liters try to flow back into vascular space. So I guess there's except that Bob and I are now working already for some time on specific glycocalyx dietary supplements. And we've seen very, very successful, almost instant results that if you administer glycocalyx substrates or polysaccharides that are identical to glycocalyx, you can almost instantly repair your glycocalyx. So that might be a way to mitigate those changes and prevent the big volume shifts and all the coagulation and inflammatory disorders that would follow if you don't take any action to try to repair that damage.
And I think another question that Brandon was asking is, would your physiology, would the system ever sort of actively degrade glycocalyx as a means to increase blood volume? Or if you needed to increase blood volume, would your physiological response to do that be through a different mechanism?
Well, let me stop share for a second here. So it's
Yeah.
a good question. So a lot of the change in blood volume can also be physiological. So if you increase metabolism by using your muscles and your exercise, or after food intake, if blood glucose levels go up and you produce or release a little bit of insulin from your pancreas into the circulation, we see a well-controlled, short-lived increase in permeability of your glycocalyx, and that's functional. So glycocalyx become more permeable, more glucose can be transported, more blood volume, more oxygen content, can be in more capillaries, there's more oxygen exchange and nutrient exchange. And if that happens in a controlled fashion, together with blood flow increases, there's recruitment of a lot of capillary volume. So the flow per capillary actually stayed pretty constant. There's way more capillaries being perfused. And that's functional. You have more supply, more exchange, but that can not take too long. So we see this about a critical duration that you can actually have increased functionality for about half an hour to an hour. So for instance, insulin releases only little short-lived peaks from your pancreas. There's not a huge surge of insulin that stays high for hours. If you would do that, and we have some clamping studies, if you clamp insulin at high levels, then you see after about an hour, then you get a lot of negative side effects. You start getting a lot of edema, a lot of protein leakage outside your capillaries. Your glycocalyx becomes hyperpermeable, and you have a high risk of blood cells sticking to the wall. So in physiological settings, it's okay to fool around a little bit with glycocalyx permeability acutely. Let's say half an hour up to an hour max. If it's longer than an hour, then you see a lot of pathophysiological consequences. Increased blood clotting, super edema, increased risk of inflammation. Also, like in high athletes exercise, if they perform, intensely, that's okay for up to an hour. If it takes much longer than an hour, there's professional cyclists, for instance, or marathon runners. Then there's a high risk of all kinds of vascular complications as a result of that. So it's a balance. So you can control it. You don't wipe it out. You hyperpermeabilize. But then you have to go back, hopefully within half an hour or before that. Like the insulin release is only for a few minutes usually, and then if it's not enough, there's a little bit more insulin, but it's not high all the time, and that's damaging. All right, let me move on fast because I'm spending a lot of time talking and maybe running out of time. We don't get to the glycocheck system. I don't.
Yeah, it's okay. We're learning a lot.
Let's see. So this is just summarizing what we've learned in those experimental studies. Glycocalyx is instrumental in sensing shear stress, producing nitric oxide, also binding antioxidants like superoxide dismutase really close to the endothelium, preventing leakage of proteins or cholesterol and fluids across the endothelium, and also physically preventing not only red cells from sticking to the endothelium, but also platelets and leukocytes. Because there's about a micron thick glycocalyx, and these adhesion molecules are on the nanometer scale, like 10 or 20 nanometers, really tiny compared to the size of glycocalyx. So it's a mechanical buffer preventing cells to contact these adhesion molecules. And whatever you do to disrupt glycocalyx by pathogenic stimuli or genetic predisposition or enzymes, then you lose your nitric oxide production by shear, less scavenging of oxygen radicals by fewer antioxidant enzymes that are present in glycocalyx, a lot of edema or leakage of larger molecules over the endothelium, and platelet adhesion and leukocyte adhesion. So realizing all these consequences, at some point it became time to move on to the Glycocheck biomedical device to start measuring in humans. So as you know, you've seen it, there's a little handheld microscope camera and the Glycocheck software. There's a method based on measuring the access of red cells into glycocalyx, how close red cells can go to the endothelium as a measure for glycocalyx damage. We now work, hold on. We work with a lot of other academic hospitals all over the world for the past 15 years. So it's a big network of people in all kinds of clinical studies that we work together with and publish a lot of papers, because we have published over 120 or 130 papers in different clinical settings using the Glycocheck, confirming that it's a important compartment in different diseases. Oh, let's go. Well, this is kind of images that you might have seen by now, that if you put the Glycocheck system in your mouth and see your red cells perfusing through your capillaries live. And then basically the Glycocheck measures two most important parameters, which is the number of capillaries that are red cell perfused. As I showed you before, any risk exposure will decrease the number of perfused capillaries over time. And then as also a measure for glycocalyx, which I'll show you in a second. So first, counting the number of capillaries. So on top would be a resting situation in a healthy individual. So 2 out of 3 available capillaries are red cell perfused. Then if your microvasculature is challenged, you will start losing blood perfused capillaries. So Instead of 2, there's only 1 capillary perfused in this example. And then in a study that we did a couple of years ago on like 400 healthy individuals in an obesity study, we classified the cardiovascular risk according to Framingham. So we had 3 groups with low risk, medium risk, and high risk, and then comparing the number of blood perfused capillaries relative to the low risk group. So the 0 level is a normal level of red cell perfused capillaries in the low risk group, and then orange is the medium risk individuals, and red are the high risk individuals. And then these are the loss of capillaries of different diameters from left to right. So the smallest ones are on the left, so the 4 micron or 5 micron, 6 micron capillaries. You see, even at this early stage of risk exposure, so these are all healthy individuals, just obese or a bit older or smoking, no organ problems yet. You already see about 30 to 50% loss of your smallest 4 micron capillaries, and also significant losses of your 5 micron and 6 micron capillaries. So you really have to zoom in on the smallest capillaries to notice that loss of density. Larger vessels, you won't see anything. So with the Glycocheck device, you can measure vessels between 4 up to 25 microns. If you would pull all your vessels, you wouldn't see this. So you really have to zoom in on the smallest capillaries and the densities of those to identify these early changes. And a few examples. So this is in a diabetes study, again, controlling normal levels of capillaries under resting conditions. In young healthy controls would be 100%. And then the blue line are older healthy controls, seeing under resting conditions. Older healthy controls have normal levels of capillaries. And then the early stage type 2 diabetics, we see, again, if you zoom in on the smallest capillaries, already a significant loss, up to 70% of their smallest capillaries in early stage type 2 diabetes. Even bigger changes in capillary density we found in the recent studies that we did in the ICU with COVID patients. So on the right-hand side, the red bars are COVID patients that needed to be put on a mechanical ventilator. Then the orange is COVID patients that can breathe by themselves. But regardless, you see these very sick COVID patients in the ICU, they lose up to 90% or 95% of their smallest capillaries. So you can imagine it's very difficult to get any nutrients in their organs and a high risk of organ failure in these patients. Well, another phenomenon that we observed with the Glycocheck device is if you compare the healthy microvasculature at the low flow situation on the left or a high flow situation on the right, that in addition to increasing blood flow from 80 to 120, so a 50% increase in blood flow, there's also a 50% increase in the numbers of perfused capillaries. And as a result, there is a matching blood volume increase at the capillary level, and red cell velocities stay very much the same in the capillaries, despite a 50% increase in the blood flow in the feeding arterioles. Hold on for a second here. Then in contrast, if you move to patients with a compromised microvasculature, not only under resting conditions, they have fewer capillaries, but also when blood flow goes up from 50 to 100, there's no further reserve capacity. There's no recruitment of more capillaries. So you stay at that same low number. And then the only thing that changes when blood flow towards the capillaries goes up is that the velocity of the blood flowing through these capillaries that are perfused all the time will increase proportionally. So also now there is a 50% increase in red cell velocity in these capillaries with a 50% or 100% increase in blood flow velocities, together with the 100% increase in blood flow towards the capillaries. And that's also illustrated in the next graph on the top right, showing on the horizontal axis the velocity of blood in the feeding arterioles. The vertical axis is the velocity of the red cells in the capillaries. So the green data points are in the healthy microvasculature, where you have de-recruitment or recruitment of more capillaries at low flows or high flows. And you see that the velocity of the red cells in those capillaries stays pretty constant, despite a threefold range in blood flow in the arterioles. And the red curve is in patients with a compromised microvasculature, so no more capillary recruitment. And then you see there's a proportional change in capillary velocity when blood flow velocity goes up in the feeding arteriole. So, and that's not very functional because if blood flow goes up twofold and the only thing that changes is the velocity of your red cells in your capillaries, then the blood just spends 50% less time in the capillaries. So there's no benefit of increasing blood flow, and it doesn't really help in terms of nutrient delivery. So my examples of that are shown here. This is the increase in number of perfused capillaries in response to a blood flow increase, in response to glucose drink in an oral glucose tolerance test in a diabetic study. So they drink a high glucose drink, and then 30 minutes later, blood flow goes up. And in young, healthy individuals, you see there's a 2 to 3-fold increase in numbers of blood perfused capillaries, helping your glucose disposal. But both the older healthy controls as well as the type 2 diabetics, there's no recruitment capacity. So although at resting, the older healthy controls have normal levels of capillaries, they don't have a reserve capacity to respond to the flow increase. Similarly, this is in a cardiology study with patients with chest pain, angina, in response to nitroglycerin under the tongue. And so when you spray nitroglycerin in a healthy control, blood flow goes up and more capillaries of blood perfused. But both the cardiology patients with large vessel disease, large vessel blockages, as well as what we call syndrome X, or angina patients without large vessel blockages and potentially microvascular disease, they don't have any reserve capacity. So although you spray nitroglycerin and blood flow goes up, there's no increase in the number of blood perfused capillaries in these patients. Well, to finalize the part on the glycocheck, so in addition to counting capillaries, we also measure the health of glycocalyx. And then we measure many thousands of blood vessel segments. And each segment, we measure the position of the red cells approximately 1,000 times relative to the position of the endothelium. So in healthy capillaries, we don't see red cells getting close to the endothelium because they bump into glycocalyx. And then when glycocalyx is compromised, they just penetrate a little bit deeper and get very close to the endothelium. So the depth of penetration of red cells into glycocalyx is called the perfused boundary region. So that's a boundary region on top of glycocalyx that they can penetrate into. And that's a measure for glycocalyx damage. So a few examples of that. If you look at that level of glycocalyx damage, again, by measuring how deep red cells can penetrate in glycocalyx. On the left are young healthy controls. Older healthy controls is about a micron deeper penetration. And age match early stage type 2 diabetics is another 1/10 of a micron loss of your glycocalyx and deeper penetration of red cells. Some other examples, this is in that cardiology study. So both the large vessel and the microvascular cardiology patients, significant increase in glycocalyx damage in their microvasculature. This is in a stroke study comparing people with significant white matter lesion spots in the brain on the MRI scans compared to people just had a stroke by one big clot in the feeding artery. And there's significant microvascular damage in the ones that have disseminated white matter lesion spots on their MRI pictures. This is again in pregnancy, so already elevated level of glycocalyx damage in normotensive pregnant women, much bigger levels of glycocalyx damage and high risk of edema and clotting problems and hypertension in women that develop preeclampsia. And then the biggest levels of increase of glycocalyx damage you find in acute inflammatory situations like in sepsis or in COVID. They lose up to a micron of their glycocalyx, so almost all of their glycocalyx is wiped out, and their endothelium becomes highly vulnerable and very high risk of organ failure. You don't want to skip this. So to illustrate this is survival curves in the ICU with really sick sepsis patients or COVID patients as a function of their level of glycocalyx damage. So the blue line are patients with a relatively healthy glycocalyx, so relatively small PBR values. And even though they can stay up to 2 months in the ICU, they all survive their stay. And the ones with a really compromised glycocalyx, you see the longer they stay in the ICU, the smaller their chance of survival in the ICU, and a lot of chances of organ failure and all kinds of complications when they have a poor glycocalyx and a very damaged microvasculature. And one more, this is a prognostic study that we did in 600 healthy individuals 6 years ago. We measured their level of glycocalyx damage, again with that PBR measure. And then we did 6 years of follow-up to see which of these individuals get a heart attack or a stroke or cardiovascular-related death, and compared the ones with a damaged glycocalyx with the ones with a healthy glycocalyx. And then we found over the 6 years that there's a more than a 5-fold greater risk of a heart attack or a stroke when your glycocalyx is damaged compared to the people with a healthy glycocalyx. And it's even much more significant than other risk factors like diabetes or family history of cardiovascular disease or using antihypertensive agents or lipid lowering agents. So just having your glycocalyx compromised is a very high risk of getting all kinds of vascular complications and what we call a major adverse cardiovascular event. And even in that group with a compromised glycocalyx, if we compensate for the other risk factors, there's still 30% of people that you would not be able to identify any other way than by measuring the health of their glycocalyx. Well, then brings us back to your system. So I'm not sure if you played already with the system, but if you do a measurement, at some point you will get a results screen, the patient screen, where you show your results. What it shows on the right-hand side, the different panels show the changes in capillary density. So from top to bottom, it shows your density in the 4-micron capillaries, 5-micron capillaries, and the 6-micron capillaries. In the middle, it shows you that recruitment capacity. Only if you do a long measurement where you measure at many different sites for the flow dependency of your capillary density, you won't get this one if you do a short measurement. And it measured your capillary blood volume based on your count of capillary density. It measures your level of glycocalyx damage, so the lower the better. And then as an overall score, we calculate what's called the microvascular health score. So you take your capillary blood volume, so the higher the better, and divide it by your level of glycocalyx damage, that PBR value. So again, the lower that value, the better. And that gives you an overall score, typically ranging between 0 and 10. So the higher, the better. The higher tells you more capillary blood volume and a smaller level of glycocalyx damage. And this is just illustrate one little challenge I did on myself. So typically, I already have pretty good scores taking all the glycocalyx supplements that we have developed over the years. But this was after a big Saturday morning breakfast challenge. So shortly after, a 6, which is on the low end for me. And if you look at the needles on the right-hand side, if I wait at 6 hours after that big meal challenge, all the needles turn right a little bit. So my capillary perfused density goes up, my glycocalyx damage is a little bit less, and then the overall score increases significantly. So yeah, taking care of food intake is one important thing that you need to be aware of. So, because one more slide, and then we'll go back to you, is if we measure the microvascular score in different settings to see if we can identify people at risk. So this was in the ER, people coming in with infections, and to try to determine if we can identify people at risk for going into sepsis or getting much worse. So this is the specificity versus sensitivity. So the two most left curves, so the biggest area under the curve, are our measures of microvascular health score in either a long measurement or a short measurement. And that's much better than the other typical clinical parameters like CRP or IL-6 that only have about 60% area under the curve, while we have about 85% area under the curve in identifying patients at risk. One more slide that I would like to share with you is preliminary data in a cancer study. So they wanted to see which of their cancer patients were at risk of getting all kinds of toxic side effects of the radiation therapy. So they classified their patients in 3 subgroups based on their microvascular health scores. So on the left, people with a low microvascular score, a medium microvascular score, and a high microvascular score on the right. And it shows people with a poor microvascular health have about 50% chance and risk of getting all kinds of toxic side effects, while people with very high microvascular health, none of the patients in that group got any toxic side effects of the radiation therapy. So I guess with that, I think I'll switch back to you and see if there's any questions.
Thanks for listening to The Future of Vascular Health. Healthy vessels, healthy future. If you're ready to take charge of your health, it's time to check out Revasca. This powerful supplement is designed to protect your glycocalyx, the microscopic layer that keeps your blood vessels healthy and strong. Revasca can help support your heart health, improve circulation, and even reduce high blood pressure. It's also great for boosting brain function, keeping your kidneys healthy, and preventing vascular complications before they start. Think of it as a way to keep your body running smoothly so you can live longer, feel sharper, and stay active. Don't wait. Take the first step toward better health today. Visit glycocalyx.com to learn more about Revasca and how it can help you protect your future.